Good evening again. On behalf of the entire University Hospitals family, thank you for joining us for our webinar on stroke. Tonight, our Life After Stroke Education and Support Series will address stroke prevention medications, driving evaluation after a stroke, and smoking cessation strategies. My name is Rich Riley. I'm a member of University Hospitals Marketing and Communications team. I'd also like to recognize my colleague Kelly, who's played an integral part in planning this event as well. A few housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed in the presentation, please submit your question through the Q&A feature, and our presenter will address questions at the end of their presentation. Also, this webinar is being recorded and will be available for viewing on demand in the near future. It will be posted on our website, and as an attendee of tonight's session, you'll receive an email with that link. Lastly, at the conclusion of our session, a short anonymous survey will display on your screen. We hope that you will take a minute to provide valuable feedback by completing the survey. It is now my pleasure to introduce our moderator for this evening. Dr. Kathy Sila is the Gilbert W. Humphrey Professor and Chair of the Department of Neurology at University Hospitals in Case Western Reserve University School of Medicine. She is the director of the UH System Stroke Program, which is recognized as a model of system integration for care delivery. She earned her medical degree at Case Western Reserve University School of Medicine. She completed residencies in medicine and neurology at Cleveland Clinic and Mayo Graduate School of Medicine, and a fellowship in cerebral vascular research at Cleveland Clinic. Dr. Sila has received numerous honors, including the UH Distinguished Senior Attending Physician and awards from the American Heart Association National Stroke Council, YWCA Women of Professional Excellence, and Crane's Cleveland Business Healthcare Hero. She is consistently named among America's top doctors by Castle Connolly and is one of their exceptional women in medicine. I am pleased to present to you Dr. Kathy Sila.
Thank you very much, Rich and Kelly, and welcome everyone to our next installment of our Stroke Support and Education series. Due to your feedback, we've put together a program tonight addressing three very popular topics. And so I hope you'll use the Q&A function to ask us questions afterwards if we've missed something that you wanted us to talk about. So I'm going to start off this evening with talking about stroke prevention medications, specifically what are blood thinners, how do the antiplatelet and anticoagulant medications work to prevent a stroke, how does my doctor choose which medication to put me on to prevent a stroke, how long do I need to take the medication, and what are potential side effects that I need to be looking out for to report if they occur. So there's a number of blood thinner medications, and they fall into two major categories: the antiplatelet agents, aspirin, which is by far the most commonly used in all vascular situations, clopidogrel or Plavix, which is probably the second most commonly used, ticagrelor or Brilinta, Prasugrel or Effient, Cilostazol or Pletol, and dipyridamole, which is in the formulation of Agrinox, which also includes a small amount of aspirin. The anticoagulant medications, of which warfarin or Coumadin has been around for decades and is probably the best known, as well as some of the new anticoagulants, apixaban or Eliquis, rivaroxaban or Xarelto, and there's another medication that's given in Europe called edoxaban or Lixiana. Some of these anticoagulant medications may also be used in the hospital, sometimes as an outpatient. Heparin, enoxaparin or Lovenox, and fondaparinux or Arixtra are typically given by injection, either intravenously or, as you can see here, injected just into the subcutaneous tissue, usually in the stomach or the thigh. And so these are basically the medications that we have to choose from when we're trying to address a patient who's had a TIA or a stroke. Now, why do we use these? Well, here's a cartoon of a ruptured atherosclerotic plaque and how that plaque causes platelet aggregation, those little white dots on the cartoon, and then causes red blood cells to aggregate as well. Transient ischemic attacks and the most common cause of stroke, which is an ischemic stroke, occur when a blood vessel is blocked and that blood flow cannot bring oxygen or nutrients to the brain. And about half of these clots do form on atherosclerotic plaques, either in the neck arteries, in the intracranial blood vessels, or in very small blood vessels in the brain. And this is why we address those clotting factors. So how do antiplatelet and anticoagulant medications work? If you've ever seen me give similar lectures like this or met with me in person, you may have heard my a clot is like a brick wall analogy. So I think of a brick wall that has bricks, which are like the platelets, and then the mortar, which are like the clotting factors that kind of stick the bricks together to make a very sturdy wall. So if you want to make that wall not so sturdy so that the clot wouldn't prevent blood flow, you can either focus on the bricks or you can focus on the mortar. Antiplatelet medications focus on the platelets, which are the bricks. They can either block factors that will promote platelet aggregation or those platelets from sticking together. They can also block vasoconstriction, where the blood vessel squeezes tight and those platelets are squeezed closer together. Or they can block receptors on the platelets themselves to make them not want to stick to each other. Any damage in the lining of a blood vessel will attract these platelets. And, think about it. This is a way that we prevent from, bleeding to death. If there's a damage in one of our blood vessels, those platelets go to the area, try to seal off that injury by adhering to it, forming that internal Band-Aid. And when they adhere to each other, a series of reactions happen where they get activated and super sticky so that they aggregate in a clot. And in so doing, they release factors that convert a protein called prothrombin to thrombin, which starts off the cascade for the mortar part of the wall. Anticoagulant medications either block the production of clotting factors that make up that mortar that stick the bricks together, and they can prevent thrombin from working by binding directly to it or activating an anti-substance called antithrombin, which prevents thrombin from working. Thrombin is a protein that's needed to cleave this protein called fibrinogen into fibrin threads, which strengthen the clot. And so now we've got like a meshwork of platelets, these fibrin strands, the mortar, and all of that makes the clot very, very stable. And that's sometimes a good thing and sometimes not a good thing. Once you have a very stable clot, it's unlikely to fall apart on its own or disaggregate. And you need a fibrinolytic drug, which actually breaks apart all those fibrin bonds and busts the clot up. And those fibrinolytic medications are clot busters. TPA, now we use TNK, and those are medications that are given within the first several hours of a stroke to break up a clot and restore blood flow to the brain. So how does your doctor figure out which of those medications to give you that really is the right one for you? Well, the first thing they do is they do some testing to determine the cause of the stroke, because it's the underlying cause that really helps us understand what kind of a clot we might be dealing with and how to best prevent that from happening. So brain imaging, a CAT scan, an MRI scan, the picture there with that white spot is a small stroke in the speech part of the brain that we can see on an MRI scan. Vascular imaging, so like that cartoon of the carotid artery with the plaque rupturing, we want to look at the blood vessels and see, are we dealing with plaque? Are we dealing with a clot that may have come from somewhere else? And, could it be amenable to some other treatment like surgery or an angioplasty or a stent, or is this something that we would address medication? So here's a CT angiogram. You can see all the bones in the neck, and here's the carotid artery in the neck. That's the carotid artery. These white patches are areas of calcification, and that represents calcified plaque. So here's an artery that's like 50% narrowed. If it's 50% narrowed, we often just manage the patients with medications, and typically antiplatelet type medications. Cardiac testing is also done. One of the first things you get done outside of the CAT scan in the emergency room is an EKG and some lab work to measure your enzymes, and then they stick those cardiac patches on you and they continue monitoring your heart rhythm. Here's a rhythm strip of an irregular heart rhythm that's called atrial fibrillation. So atrial fibrillation is a specific condition where we would use anticoagulant medications because those have been proven to be 4 times more effective than aspirin in preventing a stroke. If we can't pick up that heart rhythm abnormality on the EKG or the telemetry, we may order a cardiac monitor after discharge, which you wear for several weeks to look for more information about your heart rhythm to see whether you have a heart rhythm that might come and go and prove that diagnosis. We also do a heart ultrasound called an echo, which we can look at the heart valves, the heart chamber, how's the pump pumping. A normal cardiac pump function is 55, 60, 65%. If there's a pump failure and a heart is pumping 25 or 30%, then that may steer us one way or another in terms of an antiplatelet medicine or an anticoagulant. And we also do a series of blood tests. We do blood count markers. We measure the platelet count, chemistry values, the A1C, which is a test for diabetes, your cholesterol or lipid profile, which measures the cholesterol components in your blood. And there are a number of other cardiac markers that we can presume that it might be a cardiac cause for a stroke. And then there are coagulation blood tests. There's simple ones, there's a little more complicated ones, and then there's very extensive ones that may be done if the cause of the stroke is not apparent after the initial evaluation. And now we're looking for rarer causes of stroke, hypercoagulable disorders, or situations where the blood is stickier than it's supposed to be. The treatment guidelines really depend on that cause of the stroke and often the location of where a blockage might be. Here's a cartoon that kind of shows from the heart all the way up to the carotid arteries and into the branches into the brain. Strokes may be due to stenosis of intracranial arteries, of carotid arteries in the neck, or carotid or vertebral arteries being injured from something called a dissection. Plaque can occur on the aortic arch, the big artery that comes off the heart. There may be valvular disease causing a stroke, atrial fibrillation that we've already mentioned, heart failure or a clot in the heart after a heart attack, or a hole in the heart called a patent foramen ovale. And these are all the very common causes of stroke. And this is part of the thought process that your doctors go through if you ever come with a TIA or a stroke. These causes now are associated with specific recipes of recommendations for medications, typically have been determined by clinical trials where one strategy has been compared against another strategy and trying to find the best treatment for stroke. For antiplatelet medications for stroke prevention, you're often given a course of a combination antiplatelet regimen after an acute event. The most common is 81 milligrams of aspirin and 75 milligrams of clopidogrel or ticagrelor 90 milligrams twice a day. That's given for 21 days after many TIAs or minor strokes. It can be given up to 1 to 3 months after certain procedures like a carotid stent or a PFO closure. And it can be given up to 90 days for a TIA or stroke due to a blockage of a small intracranial blood vessel due to atherosclerosis. And then after that course of combination therapy is completed, then people typically go down to one medication, either aspirin anywhere from 81 to 325 milligrams daily or clopidogrel. Those are the most common, although there are, some other options as well. And we recommend people taking that lifelong for lifelong prevention. For atrial fibrillation, we recommend the anticoagulant group of medications, warfarin, apixaban, rivaroxaban, or Pradaxa are the 4 options. And those are typically given lifelong. If people can't take those medications, aspirin is an alternative, but as I said, aspirin is only about a quarter as protective as these medications, and so it's often not the best choice. If we think someone's at high risk for bleeding, there are other strategies like a left atrial occluder procedure called the Watchman procedure and others, which we might think about as an alternative when the best medication isn't the best one for that individual person. Well, knowing the side effects is really important. To any medication, hives, lip or tongue swelling, shortness of breath are an important allergy. It can be dangerous. You need to report that right away and stop that medicine immediately and tell your doctor about that. Bruising and bleeding are side effects of blood thinning medications. So you may be just minor bruising and bleeding, on your forearms or hips, if you hit a cabinet or, just bump yourself. That may be cosmetically displeasing, but it's not necessarily a reason to stop the medication. Even minor nosebleeds we can manage. But bruising or bleeding is a higher risk after a specific procedure where there's going to be vascular or tissue injury. So if you're anticipating a procedure, make sure that your providers know all of your active medications. You may be asked to stop or hold the medicine for a number of days before having a procedure. And very often your doctor who prescribed that medication is asked if this is a safe thing for you to do to stop the medication for a procedure. Bruising or bleeding can also occur after an injury. So if you fall and hit your head and have a headache that won't go away, if you're involved in a car accident with significant injury or a kitchen mishap like cutting yourself or a serious shaving mishap, that's something that you need to be aware of. Put pressure on the area, and if it doesn't stop bleeding, then go to the emergency room to have it treated. The blood thinning effect can also be accentuated if combined with other medicines that have blood thinning effect. Some of these people know about, like anti-inflammatory pain relievers. The risk of having stomach troubles when taking aspirin plus Advil is considerable. And so your doctor needs to know about that if you're taking over-the-counter medicines. But less people know that vitamin E has a blood thinning effect. So do high doses of fish oils, ginkgo and turmeric. And so even though they're not medications, if they're things that you're taking that are over the counter, it's really important to let your doctor know. Important tips when medication is recommended. And this is for all medications. Take them as you were directed to take them. Sometimes if you take half the dose, you don't have any of the protection. So, don't try to customize something without getting advice. If you have side effects or you can't afford the medicine, talk with your doctor. See if there's a less expensive alternative, or if you complete the course of that medication, you can move on to something else. Many medicines are not safe to stop without medical advice. And plan ahead so you don't run out. Some medications, like some of the anticoagulants, have a short duration of action. And if you stop the medicine for 2 days, you're not protected anymore. And just to be safe, bring a list of your medicines to each doctor visit, or throw your pills in a bag and take them to your doctor visit to make absolutely sure that we've got the right list in our medical record, and to also go through and ask, are these still all the best medicines for you? Or should we relook at your medication list? All right. So moving on from medications to community mobility and the driving assessment. These are really common questions. I want to introduce Josh Washak, who's an occupational therapist and a hand therapist. He works at our Geauga YMCA outpatient rehab since 2012. Josh has been a great resource for us. He received his master's degree from Cleveland State and has been providing driver evaluations since 2016. So he's an expert. Josh, welcome.
Welcome. Thanks for the introduction. Appreciate it. All right, everybody. So Geauga has been doing driving evaluations for quite some time. This featured right here is our newer driver assessment. And we received this in December of 2021. Probably 10 years prior to this, we've been even using our prior simulator, which is now located at St. John, and they're using it there also. All right, that's it for that slide.
I'm trying to advance. Hold on. Okay, sorry.
That's all right. All right, so Geauga, which is where I'm located in Chardon, is one of the locations. Then we have St. John. We also have assessments at Lake West Hospital, which I believe they're also in the process of obtaining a newer assessment simulator. And at this point, UH does not do any on-the-road assessments, so we only do clinical assessments. So if for some reason, we deem that we don't have enough information, that would be the next step, would be going to an on-the-road assessment, which is the gold standard at this point for driving assessments. So abilities for the clinical assessment, people have to be able to reach and sustain grasp on the wheel with both arms. So this can be somewhat difficult for some of our stroke patients. If people have limitations with range of motion and they can't hold the wheel, or they cannot get to that part of the wheel, then that is kind of a red flag for me, because that's going to mean that they're going to require some type of a modification to their car. And that is not something, as the provider with my current level of assessment, I cannot technically write a prescription for somebody to have a spinning knob or any kind of modifications. So either other than that, they need to have the right amount of strength in the right lower extremity to be able to lift their leg and to go between gas and brake. And then also coordination for going back and forth with the lower extremity. So as I said before, any type of modifications would have to be done following an on-the-road assessment. And when you have that type of rehab, they kind of go with you. They go over that type of modification with you and then give you some training on it to make sure that you can utilize it in your car. All right, and then vision obviously is very important when it comes to driving assessments. So we need 70 degrees of side vision in each eye and approximately 20/40 vision to drive without restrictions. Usually I get some information about the patient's last visual assessment, when they last saw the doctors, what kind of limitations they're having. Do they have glaucoma? Do we have cataracts, anything like that? Is that something that's been taken care of in the past? Because that would obviously affect your vision. All right, so if anybody has any kind of visual limitation following your stroke, and when I say that, it's called like a field cut. So you would only have limited view out of your eyes to not be able to see your total surroundings. We do screen for that, and typically that's well known prior to when they're coming to see me. So I look over everybody's information prior to them coming, but so every once in a while something gets missed. So we look at that to make sure that you have your field of view. And then if that is the case, that's a little bit more intense rehab as far as retraining and modification. So that would be an on-the-road assessment that had to be completed. And again, this is completed by a certified driving specialist. And this person is somebody that does the driving evaluations pretty much every day, and that's all they do. Okay, so if somebody had previously failed an on-the-road test and their recommendations were, not to drive, it would be indicated that the patient would return back to an on-the-road versus having a simulation assessment. Again, because the on-the-road test is the gold standard at this point. All right, so our evaluation is split into two parts. I call it paper and pencil, and then simulation. It could take anywhere between 1.5 hours to 2 hours altogether. It all really depends on who's coming. I see a lot of seniors with our assessment in addition to stroke patients. If somebody is having a harder time cognitively, it's going to take longer. It just takes longer to get through. Takes longer to get through all of our cognitive assessments, and also, requiring repeat instructions. And all of those things also factor into my ultimate decision and recommendations going to the physician that ordered the assessment. All right, so when people come in, kind of just get a little bit of understanding of what's going on with them, why they're here, how things are going so far from their point of view. We talk a little bit about your day-to-day stuff, how you're doing with getting dressed, how you're doing with doing things around the house. What is it like now? What was it like prior to your stroke? Sometimes I'll say, are you paying bills? And like, I've never paid bills. So obviously I'm not going to expect you to be doing something you weren't doing previous to the, prior to having the stroke. We do range of motion of the arms and legs to make sure that you have adequate motion to be able to do the things that we need to do behind the wheel. We also look at your strength from your arms and legs to make sure that you're able to do what you need to do with regards to going gas to brake and so on and so forth. Then we do essentially a visual assessment that looks at your peripheral vision, and that also looks at how you do tracking an object without moving your head, just using your vision. And then following that, we do a confrontation, which is basically where the doctor has you or anybody has you follow the pen to your nose to see how your eyes converge. Following this, we do it's a 6-point balance assessment. It's called a Romberg. Essentially, if you get 6 out of 6, you have pretty good balance. If you get 1 or 0, then you're at a higher risk of falls, and higher risk of falls is there's a strong correlation between that and poor outcomes and increased crash risk. Other things that we complete would be cognitive assessments. I do several. One is called the MOCA. It is a standardized assessment, which means that it's given the same way to everybody, and you have to be trained to complete that assessment. And it basically ensures that everybody's getting the same questioning, and then also, you know, same questioning, and then also it makes the scoring essentially the same among everybody else. Okay, so this is basically what it looks like from behind the driver's seat. We have 3 screens. The steering wheel is movable up and down, and then the seat also comes forward and backward. On this, you can't see it on this. This actually has a 3rd pedal, which is meant to train somebody who had either a stroke and you cannot use that right leg for hitting the gas, or maybe somebody who had an amputation. So this is something we could use as like a pre-rehab. Okay. When anybody gets behind the wheel for the first time, they're generally pretty anxious. I do my best to make that not so bad, but either way, we do a couple warm-ups. The first one is essentially having the person just go the right speed limit and then stay in the correct lane. There's nothing else involved with it, no braking, no turning. And then following that, the next scenario involves braking, turning, and using signals. And then after that, we go into essentially reaction time on it. There's typically about 5 scenarios or five trials of the reaction time. And what we're trying to get is the least amount of time from going from your gas to your brake. Following that, there are typically 2 scenarios that are picked based off of generally the area you live in. I try to make it as appropriate as possible. And these all have different, there's all this different things that happen in each scenario. Typically, it's a little bit more exaggerated than what you would expect. You don't have people running out in front of you multiple times on one drive home, but that's kind of what we're expecting here. And that's what we see here. And I prompt people to be aware and be expecting that, because I think that's fair. But also ultimately, we're looking to see what your reaction time is and how you react to something happening. You know, I have people that do things just the right way, and then I have people that go off the road, or I have people that cross the yellow lines and go across center. So I mean, I've seen pretty much everything happen. But essentially, the last thing would be a divided attention task. And this essentially simulates people doing things in the car, because obviously when we're in the car, we're focusing on multiple items. People are using their turn signal, they're looking to the right, they're adjusting their radio, and all of those things you're doing while maintaining focus on the road. Okay, so preparation for the assessment. The best thing that you can do is be active. Do as much as you can in the house. Anything that's a multitasking item, such as cooking, attending to 2 different things at one time, essentially just making sure that you are able to focus on more than one thing. I always recommend people review the rules of the road from the BMV. That's another part of our assessment, to kind of just see how you are, and you know, are you up to date with what the ideal correct knowledge should be. And then there's also games that I recommend people play. So chess, mazes, all of these address your attention to task, and they also address your ability to focus on more than one thing at the same time. You have to plan, and you have to anticipate other things that might happen. So other games in there, all good. So following this assessment, I typically put it all together, which takes some time. The evaluation is then sent to the referring doctor, and that referring doctor is the one that gives the results to the exam. And that's usually sent in, it's going to be in your medical record, usually within a week.
All right, thank you so much, Josh. And
Yeah.
just to remind everyone, we'll have time for questions at the end. I'd now like to introduce the next speaker who's going to talk about stopping smoking. So Laura Lucchese is a clinical nurse and a certified tobacco treatment specialist at University Hospitals. She holds a master's degree in exercise physiology and a bachelor's degree in nursing. She received her tobacco treatment specialist training and certification at the Mayo Clinic Nicotine Dependence Center. She's currently a coordinator for the Tobacco Treatment Counseling Program at UH. Welcome, Laura, and thank you for speaking with us tonight.
Thank you so much for having me. Hi, everyone. If you're a smoker, you already know that there are a lot of good reasons to quit, especially if you've suffered a stroke. Smoking places you at a significantly higher risk of stroke than non-smokers. The research shows that you're actually 3 times more likely to have a stroke than non-smokers. Cigarettes have approximately 600 ingredients in them. And when cigarettes are burned, this creates more than 7,000 chemicals. So when you inhale that tobacco smoke, those chemicals enter your bloodstream, and that changes and damages cells all around your body. So how does smoking specifically increase your risk of stroke? Well, smoking thickens your blood, which raises the risk of blood clots and narrowing of the arteries. It also cuts down on the amount of oxygen in the blood, so your heart has to work a lot harder. Smoking also affects your cholesterol levels, which is another risk factor for stroke. And then we also have to think about all of the other ways that smoking harms our bodies. It's not just our heart and our lungs. Smoking affects nearly every organ in our bodies, causing many different kinds of cancer, chronic disease. It even contributes to the development of many autoimmune diseases, including rheumatoid arthritis. When it comes to secondhand smoke, there is no safe level of exposure. So if you live with someone else who smokes, or you spend a lot of time around people who smoke, you are also at high risk for developing the same health conditions as they are. Third-hand smoke, probably not something a lot of you have heard of, because there's a lot of emerging research that's coming out now. But third-hand smoke is residue of from tobacco smoke that sticks to walls, furniture, clothes, skin, and other surfaces after someone has smoked in an area. This is also a potential for, potential health hazard to non-smokers, especially children. There's chemicals in third-hand smoke that are known to be hazardous to health. And it's really tough to clean this too. We can't clean it with just your everyday cleaning products. That's something else to be mindful of. So the great news is that it's never too late to quit. Our bodies are very resilient, and they start to heal almost immediately after quitting. The cardiovascular and pulmonary benefits are immediate. Your cancer risk is lowered after a few years. And then after 5 years, your risk of having a stroke is around the same as someone who has never smoked. So, the benefits really are endless. Reducing the amount that you're smoking, unfortunately, is not enough to experience those benefits. You do have to quit entirely, but reducing to quit can be a good quit strategy to use. And then this is just a visual showing, a timeline of all of those health benefits that occur after you quit. So even just after 20 minutes, your heart rate decreases, your blood pressure decreases, all the way up to 15 years, where your risk of heart disease equates to that of a non-smoker's. Okay, so planning to quit. It's extremely important to go into quitting with a plan. Creating a quit plan is going to greatly improve your chances of stopping for good. Having a plan helps you to set expectations, line up the support that you need, prepare for potential cravings that you might experience, and come up with some strategies for how to work through those cravings. And it also helps you to stay motivated, because this is a tough process. So first, try making a list of all the reasons why you want to quit, or why it's important for you to quit. What is motivating you to do this? There are a lot of different reasons why quitting might be important for you. Number one for most people is their health. Improving your current health and lowering risk for disease in the future. Saving money is another big one. You think about how much you spend on cigarettes per week. Figure out how much you would save over a month, over a year. Think about all of the other great things you can do with that money instead. Not exposing your family and friends to secondhand smoke. The list goes on and on, but physically making a list is not only going to help you get started, but it will help keep you motivated during this process as well. So the next thing is to choose a target quit date. Try to pick a specific day within the next month to quit smoking, and mark it on your calendar. I always tell my patients, try to pick a day in the near future. If you pick a day that's too far out, it's really easy to lose track. But maybe picking a day 2 weeks from now would be good, because it gives you time to mentally prepare for that day. You might want to pick a random day, or you might want to pick a day that holds special meaning for you, such as a birthday or holiday. But it should be a day that's likely to be less stressful than other days. There's some things that you'll want to do in preparation for your target quit date. And one of the most important things is to talk to your provider about medication options. This is really important. Going the cold turkey route is really not recommended because the success rates are so low. And even those who do quit cold turkey, the large majority will relapse relatively quickly. You have to look at tobacco use as any other chronic disease. You take medication for high blood pressure, for diabetes, for high cholesterol. Why wouldn't you take medication for tobacco use? Nicotine replacement therapies specifically will double your chances of quitting and staying quit in the long term, as long as it's used correctly and if it's used for a long enough period. It comes in the patch form, gum, lozenges, nasal spray, inhaler. Using more than one form is actually a lot more effective than just using one form alone, and it's very safe to do that. It's usually something that I recommend for almost all of my patients. Most forms are available over the counter. You do need a prescription for the nicotine nasal spray and the inhaler. So if that's something that you're interested in, your provider can put in a prescription for you. Besides NRT, there is varenicline and bupropion, and these are both prescription medications that are used for tobacco cessation. Varenicline, or you probably know it as Chantix. This works on the nicotine receptors in your brain to reduce withdrawal symptoms and to reduce cravings. This is a medication that works really well for many people. Bupropion, or Wellbutrin or Zyban. This is actually an antidepressant that was found to work really well for tobacco cessation, although it doesn't work quite as well as varenicline or nicotine replacement therapy. So we don't prescribe this one quite as often. But talk with your provider about which medication might be right for you. And then finding a support group or a support program is also extremely important. It can be really beneficial leading up to your quit date, because they can help you come up with strategies to prepare for that day. There's a lot of different programs that are available just depending on what you prefer. There's individual or group counseling, telephone quit lines, such as the 1-800-QUIT NOW, the Ohio Quit line. Here at UH, we do offer individual behavioral counseling, and we can meet with patients both in person or virtually, just whatever is more convenient for you. Insurance does cover counseling, and if you have Medicare or Medicaid, you do get 8 sessions a year of counseling that's covered. So that's really nice. And we do offer a monthly support group as well. So you can meet other people who are also on a quit journey. And then it's helpful to make a list of your specific smoking triggers and routines. You might smoke with coffee after eating or when you're stressed. Identifying your specific smoking patterns will help you to prepare and come up with a plan for alternative ways to deal with those triggers without smoking. Tell people, let your family, your friends know about your quit date. Use them as a support system. A lot of people don't want to share that they're trying to quit because if they end up relapsing, they don't want to have to share that they, that they weren't able to stay smoke-free. They might be a little bit embarrassed, but these people care about you. They want what's best for you. They're going to be there to support you. So use that to your advantage. Clean house, get rid of any smoking supplies, ashtrays, lighters, matches, any smoking paraphernalia that you have in your car, your house, your office. That way it minimizes any potential triggers when it comes to that quit date. Stock up on substitutes, keep gum, mints, straws, toothpicks, keep those handy to use to help satisfy that oral fixation. And also find some items to keep your hands busy as well, such as a stress ball. So quit date has arrived, and getting through your quit day can be very challenging, both physically and emotionally, especially when those cravings hit. So these are some good tips to use when that day comes. Use nicotine replacement, gum, lozenges. Those are not only going to help keep your mouth busy, but it's going to give you that nicotine as well. Remind yourself why quitting is so important for you. Stay active, get out, go for a walk. Do your best to avoid triggering situations. I know not all of them are going to be completely avoidable, but do your best to minimize that. Attend a support group, go to a counseling session, practice stress management strategies, and keep your hands and your mind busy by doing different things like reading, doing a puzzle, coloring, knitting. I've had a lot of patients take up knitting when they've quit smoking, believe it or not. So just, there's a lot of good tips there that you can use when it comes to that quit day. All right, let's talk briefly about relapse. Most people who want to quit have tried at least a few times and have gone back to it. This is normal. Relapse should never be thought of as a failure. Every time you try, you're giving yourself another opportunity to succeed. You're never starting over, you're starting from experience. So each time you quit, you learn more about what works for you specifically and what doesn't work. And you can use that knowledge going forward when you try to quit again. For most people, relapse does occur in the first week after quitting. That's when withdrawal symptoms are the strongest. So try to lean on as many support resources as you can during that time. Friends, family, use medication. And then just very briefly, lastly here, e-cigarettes. I'm not going to talk about a lot about this at all because this can be a whole presentation in itself. But I know most of you are probably aware of what these are. They're battery operated devices. They heat nicotine into a vapor that you breathe in. These are not FDA approved for tobacco treatment. So we do not recommend using these to help you quit. combustibles. There is slight harm reduction in switching from tobacco to e-cigs, but there are still a lot of health risks. And we don't know yet if those benefits outweigh the risks. So we do recommend using one of the 7 FDA-approved medications for tobacco cessation. And then just some words of wisdom from some former tobacco cessation patients of ours. If you just want to read through those, I'll read the last one because that's the best one. This was probably my 10th or 11th time trying to quit. I never had the resources those times that I did this time around, and it made a huge difference. The nicotine patch and gum were my saviors, along with counseling. I am extremely grateful.
All right, well, now we come to the portion of our evening where we can do question and answers. And already some questions have popped up here. I always learn things at these sessions. So I really want to appreciate my co-presenters today. One of the things that comes up is that people do want to quit smoking. They're not quite ready to start on the path, but they're thinking about it, like that pre-contemplation. So what are the things that they can do to start getting them ready to plan? Is there some activity that everybody could do, even if they're not quite on the journey yet?
Absolutely. One of the best things you can do when you are just kind of in that pre-contemplation stage is start tracking your smoking. Set aside a few days or a week to keep a cigarette log. Just start from the moment you wake up to the moment you go to bed, and just keep a log of the time that you have a cigarette, maybe what the situation is, what you're feeling. And then being able to, go back and look at that cigarette log at the end of the week, that's really eye-opening for people. It helps you to identify or start identifying what your patterns are, and just helps you to become more aware. So that's a really good place to start if you don't know where to start, or if you're not exactly ready to get started on the quit journey.
Great, thank you. And this one is for Josh. It looks like it's from the spouse of someone who's logging in because they had a stroke. And your comment about people who are at risk of falling are also at risk of crashing. So are driving screening evaluations like this recommended for people who are falls risk too?
Well, so if somebody's like a significant falls risk, then it's not a bad idea to have them looked at. It's based off of research. I guess I should have had that piece to share. But yes, if somebody's a significant falls risk, that could increase your risk of crash.
Wow, very interesting. How often do you do these assessments, or how often do we offer them across the health system? Are they pretty accessible?
I would say they're fairly accessible. From our facility, we do them twice a week. I believe that Lake West does them even more often, and I'm not really certain on St. John, but it's something that's offered at least on a weekly basis. We try to ensure that that they're available so that people aren't waiting a long period of time.
That's great. So here's another question for Laura. If someone's using a nicotine replacement therapy, how do they actually get off nicotine? Isn't this just kind of feeding their addiction?
Yeah, that's a really good question. So when it comes to tobacco use, nicotine is really not what we're worried about. We're worried about all of the other toxins and chemicals that come along with the combustible products. Nicotine itself is actually relatively safe. It's not totally benign, but it's pretty safe. The nicotine in the nicotine replacement therapy products is actually different. It's more medicinal. It doesn't last as long in your body. It's delivered much slower. So there's virtually no risk for getting addicted to the NRT. And there's also a very, precise system of tapering you off of it. There's different levels with the patches. There's 3 different dosage forms. There's 21 milligrams, 14, 7 milligrams, so the goal is to taper you off of it over time. The same with the gum and the lozenges. There's 4 milligrams, 2 milligrams. It's a very systematic approach to making sure you get off of that nicotine replacement therapy.
Great, thank you. Here's a question for me. Years ago, my doctor started me on a blood thinner medication that has dipyridamole, and I struggle taking this medicine because I think it gives me headaches. What should I do? Well, that's an excellent question. Dipyridamole was a very common medication that was used. It's less often used nowadays because we have other alternative medications. But headache, migraine type vascular headaches was a side effect for some patients that can be either mild or intermittent or actually pretty persistent. So this is definitely a situation where we have alternatives to that medication. And I would definitely talk to your provider, complain that, you think you're having side effects of this medicine, and could it be switched out for something else to see if those symptoms go away. Okay, here's another one for Josh. The driving evaluation. Will this be covered by my insurance?
Yeah, so UH's driving evaluations are completed as an occupational therapy evaluation. So it's covered from, I don't think I've ever had it where it's not been covered under anybody's insurance that we've taken. So yeah, it's billed as just an OT evaluation. Whereas an on-the-road assessment, again, not the same, but an on-the-road assessment would be out of pocket. So sometimes if people are like on the fence of should I be going to on the road or this, sometimes it's never a bad idea to start here because it's covered. And then if we deem it to be necessary, then you could go for that.
Got you. That's excellent. And here's another one from Laura. You mentioned about using more than one form of nicotine replacement therapy. What can you clarify? What did you mean by that?
Yeah, so we almost always recommend a combination therapy, and that usually looks like the nicotine patch, which is a long-acting form of nicotine replacement. So it gives you a very slow, steady release of nicotine throughout a 24-hour period. So that helps you to avoid the the ups and downs of nicotine withdrawal throughout the day. And then we like to add in a short-acting form of nicotine replacement. So gum, lozenges, the inhaler, and that gives you a really quick dose of nicotine. So it's helpful for breakthrough cravings that you still might experience through the day, even with wearing that patch. So they work very well together. It's very safe. And it gives you your best chance of quitting and staying quit.
And a follow-up question, how long will it take for me to get my sense of smell back?
It's very different for everybody, just depending. I see people after about the month to the 2-month mark, where their taste buds start to reawaken and their sense of smell start to reawaken as well. For some people that happens sooner, for some people that happens later, but that's what I see on average.
Good. All right. Thank you. And here's another one for Josh. I think my husband needs a driving evaluation. How do I get him to get one done? What's the mechanism?
So, I mean, if you feel like it needs to be completed, then the first stop, I mean, if you're seeing a neurologist, then you can talk to them about it. But if you're not seeing a neurologist, then any of your normal, regular, doctor, your PCP could write an order for you. But, discuss it with them. If they think it's appropriate, then an order can be written and then we can basically schedule you.
And on that note, we have gone through another really fast hour. I want to thank all of our presenters for such useful and helpful information. And I want to actually thank all of our attendees. Please send the feedback information and give us ideas about things that you want to hear about. Rich, it's up to you.
Okay, well, I agree. Excellent presentations by everyone. Thank you all so much for your time. To our participants, thank you so much for taking time out of your evenings to join us as well. Again, if you'd like to make an appointment with any of our presenters, you can call 216-930-5836. And if you're looking for more information on stroke, a good resource is our website, uhhospitals.org/stroke. Again, this concludes tonight's session. Thank you for attending, and we hope you join us for upcoming webinars. Have a great evening.